Trying to.
Yeah.
Make some
changes.
I make enough that don't make sense.
You balance it.
Exactly.
They're no brainer.
All right. It is. There we go. It's 12 o'clock, so we'll go ahead and get started. I want to welcome everybody to Medical Grand Rounds at the University of Colorado. Very pleased to be back in person this year. We are going to run this as hybrid, but I'm encouraging everyone, there we go, to come to the Cribbie Auditorium in RC2, because I think it is more fun to be here in person, and we're about 90% full this week, so we're doing well on that front. Upcoming talks, just so folks know what the schedule looks like, on September 21st, we're going to have an all virtual presentation. So despite what I just said, do not come here on the 21st. That'll be our DOM Quality and Safety Improvement Conference run by the Quality and Safety folks in the Division of Hospital Medicine. So that will be only virtual. And then on September 28th, we're happy to welcome our new division head of rheumatology, Dr. Christy Kuhn, longtime faculty member, but new division head, to speak on spondyloarthropathies. I want to remind everybody that we are offering CME and mock credit for all medical grand rounds this year. So please use the QR code that was up here a minute ago, was also sent to you via email. And then questions are going to come primarily from our live audience this year, since we are so numerous, but we'll also have the chief medical residents, appreciate your help, watching the Zoom chat and making sure that questions can come from our virtual audience as well. So now I'm very pleased to welcome Dr. John Messenger here to give medical grand rounds. He is a professor of medicine in the Division of Cardiovascular Diseases here at the University of Colorado. He's an interventional cardiologist at UCH, the VA Medical Center, as well as Colorado Children's Hospital. He's also the director of interventional cardiology, the clinical director of the University of Colorado Hospital Heart and Vascular Center, the director of cardiac catheterization laboratories, the medical director of cardiovascular pre and post unit, all here at UCH. He did his undergrad work at the University of Southern California, where he was also a medical student. He got his medical degree with highest honors, graduating AOA. He was a resident at the University of California, San Francisco, and then came to the University of Colorado for his cardiology fellowship, where he also stayed for his interventional cardiology training. Dr. Messenger has held and continues to hold many leadership positions in cardiology that exert really a national and international influence. He is the recent former chair of the American College of Cardiology National Cardiovascular Data Registry, Clinical Science and Quality Committee. He served 3 years as the governor of the Colorado chapter of the ACC. He is the current course director for the Society of Cardiovascular Angiography and Intervention annual scientific sessions. And in addition to that work, he has chaired or co-chaired 20 other committees during his career in ways that all advance interventional cardiology across the country. His work is currently supported by an American Heart Association Rapid Response Grant to COVID-19. He's been previously supported by a U01 from the NHLBI, an U18, an NIH NHLBI SCORE grant, as well as several others. And knowing John as I have for a very long time, I want to also mention that his work is supported by an incredible amount of dedication and time. He is currently the PI or site PI on 6 active clinical trials, ranging from the interventional cardiovascular techniques he uses on both mitral valves as well as aortic valves, all the way out to stem cell therapy for heart failure patients. And because it's cardiology, I'm not going to read them, but they all have great names. His work has led to over 100 original publications and twice as many presentations and invited talks. It really is my pleasure to welcome Dr. John Messenger.
Thanks, Jeff. We were trying to figure out how long we worked together, and it's so long we can't remember, which is a good sign. But thanks, everybody, for the opportunity to present here. This is something that was set up, I think, during COVID or before COVID, and has been about 18 months in delay of getting here. So I'm going to try to get through this and then leave some time at the end for questions, because this really is a high-level review. So much has gone on in the last 3 years under the COVID umbrella that there's just been an inordinate push nationally and internationally to move forward transcatheter heart valve intervention. And so today I'm going to go over sort of this disruptive technology, where we stand 10 years after we introduced TAVR in 2012. See if I can get this. Any of you, this is the CME MOC credit slide. So if anybody needs that, I'll give everybody the requisite 30 seconds to open your phone and take pictures. And all right, everybody got it? Perfect. All right, I've got some disclosures just related to being a site PI. I'm not a national PI on these trials. We do get institutional grant support here at the University of Colorado from Philips Medical Systems as their development site for advanced imaging. Briefly, our outline today, I'm going to give a background of valve disease prevalence because I think this speaks to where we're going to be going in the next 10 to 20 years in terms of transcatheter valve therapies. Go over the data supporting current aortic valve therapies, and I'd like to get everyone here caught up with where things stand with TAVR approval in the United States. Talk a little bit about nowadays who should get surgical AVR. We no longer really think about TAVR only, but surgical AVR still has an important role to play. And then in the last third of the talk, I'm going to go through the status of transcatheter mitral valve therapies, which, believe it or not, has been going on twice as long as TAVR, but still hasn't led to great FDA approvals. And then finish up with tricuspid valve therapies, which is referred to as the forgotten valve. So background, we had been doing surgical valve replacement as the gold standard for particularly aortic stenosis and mitral stenosis since the 1960s. So when TAVR came into play in 2008, 2009, 2010, it was coming into a milieu of 50 years of open heart surgery being the gold standard. So it had a lot of barriers to sort of jump over, a lot of hurdles. And I'm going to kind of go through the historical timeline of how we were able to do this with such a disruptive technology, which really moved this from a surgeon-dominated thing to a heart team approach. To put in perspective also the explosion of this and where our population is going, in 2011, the year before we started transcatheter aortic valve therapy, the STS database, which collects data on 95% of procedures performed in the United States, identified 48,000 patients who underwent both mitral and surgical aortic valve replacement. So just keep that number in mind, 48,000 in 2011. In halfway through TAVR, once we started with all the high risk and inoperable patients getting TAVR, the surgical mortality was 2.2% in 2016 for aortic valve replacement, and it is double for mitral valve replacement. So something to take home, mitral valve surgery is always at least double the mortality of aortic valve surgery because it affects the subvalvular structures and myocardium much more than the aortic valve. And unfortunately, as all of you know, caring for patients in our hospital, as our patients are aging, their comorbid profile is markedly expanding with them. So that's sort of the background of valve therapies. Here's our problem. If you look at the population from the US Census Bureau and projections, in the green legend is age greater than 65. Between 2020, 2 years ago, and 2050, there's going to be a 92% increase in population over age 65 and an almost 200% increase in patients over age 85 during that time period. So we're skewing our population to this much older group. Why is that important? Well, that's important because this is the exact demographic where we start to see degeneration of valve function in people in the United States. These are data from the ARIC, Cardia, and CHS cross-sectional studies showing that all valve disease is up to 10 to 15% of patients over age 65 to 75, with about twice as much mitral valve disease in that population as aortic valve disease. So this is kind of the perfect storm that we're going to be seeing, which is a enriched patient population over age 75 that all have comorbid conditions and lots of valvular heart disease. Aortic stenosis comes in a couple different flavors. We'll go through some of these things. Rheumatic, we're really not seeing quite as much rheumatic valve disease anymore, which is thickening and fusion of the leaflets of this tri-leaflet valve on the bottom right. The middle valve, the bicuspid valve, is something that we're struggling with because it really behaves, it's an oval valve, not a round valve. So TAVR is challenged by that. And our typical thing that we do battle with is degenerative calcified aortic stenosis on the bottom left. This wouldn't be a talk on AS if we didn't introduce the Ross and Braunwald slide that all of you hear. And this is really when we quote patients and talk to them in clinic, these are the landmark data from observational care of aortic stenosis before we had meds, which don't work, and therapies. This is what happens. So if you look in the top right, when people say half the patients with heart failure will die within the year, these are the data that really resulted in that. At 2 years, nearly 100% of heart failure patients were dead with aortic stenosis. If they had syncope, they lived a little bit longer. If they just had some angina, they lived even longer. But by the time we're seeing people with symptomatic exertional dyspnea, elevated BNP, and heart failure, it really portends a very poor prognosis if you do this. And the big question is, when do we intervene? You see this long latent period where people have mild and then years of moderate aortic stenosis and then years of severe aortic stenosis, we in cardiology are arguing amongst ourselves what makes up moderate, moderately severe, and severe. And hopefully after today, you'll understand that in the future, we may be much earlier on the curve in terms of treatment. Going over findings of aortic stenosis, when I trained, we used to get into things of crossing the valve and measuring peak-to-peak gradients and mean gradients. And the realities are that TAVR and the regulations around TAVR by CMS have actually made this quite simple for me as a plumber. The FDA was very smart, and they just picked a couple parameters that we'll go through and have really made it simple to meet the national coverage decision. And it's actually made this a lot simpler. So this the echo on the bottom right, you can see the beautiful two leaflets of the mitral valve opening and closing. And right next to it, you see the thickened calcified leaflets of the aortic valve not moving well. In the right is the continuous wave Doppler. We're measuring the peak velocity, and understand none of these we ever measure pressures. All these pressures are derived from velocity measurements that we convert to a pressure. So they're estimates at best, sometimes accurate, sometimes inaccurate. But in general, the current diagnosis is echo-based. It is the definition for the national coverage decision and how we navigate the clinical trials for aortic stenosis is a mean aortic gradient over 40 millimeters mercury, or a peak velocity over 4 meters per second. And then you probably have to have a valve area that's reasonably compromised. The nice thing about the United States is most people are pretty big. Their valve areas indexed are usually less than 0.6 and 0.5. The two places we get burned and the things that are controversial are these areas of, you'll see the terms low flow, low gradient aortic stenosis and paradoxical low flow, low gradient aortic stenosis. Low flow, low gradient aortic stenosis is heart muscle doesn't work well and doesn't move much blood across the valve. So if we improve that heart muscle working and more blood goes across the valve where it can be more stenosed, it's real aortic stenosis. So that's what we use dobutamine studies to see if we can augment flow across the valve. And if it is a tight, rigid valve, the velocities of blood flow will increase. The more confusing one to people is paradoxical low flow. And this is actually something we see far more commonly, and we just haven't recognized it in cardiology. Probably Dr. Quaife here, who does MRI or our nuclear knows. But women in particular who develop aortic stenosis develop significant hypertrophy. And the way that they deal with that is they compromise their LV stroke volume. So as they get worsened aortic stenosis and thicker heart muscle, they have less volume moving across the valve. And so we underestimate the true obstructive nature in some of those patients. That can be brought out also by either exercise or dobutamine. We've now have integrated, you'll be seeing us doing more aortic valve calcium score. This is not coronary calcium score, but aortic valve calcium score, where under several studies have now pooled the data. And we think that a aortic valve calcium score above 2,000 in men and above 1,200 in women, plus or minus 10%, is indicative of severe aortic stenosis. And so in these intermediate cases where people are sitting here arguing over moderate versus severe, we can move forward with that diagnosis. So these are the take homes for diagnosis that I want everybody to kind of understand for aortic stenosis. Well, why did we get into TAVR? We got into TAVR because of these clinical, anatomical, and non-traditional risks for open heart surgery. And all of you guys know about these things. There are some anatomic things that make open heart surgery bad, porcelain aortas where you can't cross-clamp the aorta, previous bypasses running up the sternum. But there's other things like frailty, which doubles your operative morbidity and mortality that are more non-traditional, as well as cirrhosis. And Dr. Bowles here, his pulmonary hypertension patients are some of the worst to try to get through left ventricular interventions because they don't have a good right ventricle to preload that. Well, I titled this a disruptive technology, and this is why it is. On the left, you've got open heart surgery with a direct surgical valve replacement of a stopped heart on cardiopulmonary bypass. On the right, you have a catheter being put in through someone's groin with no general anesthesia under conscious sedation with them awake talking, and they get a valve and roll out of the hybrid operating room within an hour with a brand new heart valve with no incisions. So you could see how this is a fairly disruptive technology in terms of the field of cardiovascular medicine. The first TAVR was done 20 years ago by Alain Cribbie. It was called the Cribbie-Edwards valve. He went retrograde with this valve and actually did a transeptal puncture and put it up through. In classic French fashion, this is them toasting with the patient with champagne immediately post-procedure. And this was the first case done and showed proof of concept, and it just took off in Europe and Italy and Canada from there. Unfortunately, in the United States and in Japan, we were woefully behind by almost 10 years in terms of the clinical pivotal trials. And we didn't get up and running and didn't get FDA approval until 2012. And I'll go through some of that timeline. The partner study was really the pivotal trial. In the cohort A that people deemed patients were not operative candidates, they didn't have much choice. So they had about 350 patients. Half of them got TAVR valves, half of them got observational therapy. 50% of the patients were alive at 1 year follow-up. In one arm, 75% alive in the other arm. So TAVR was a home run over doing nothing. They then went on and identified a high-risk cohort for this. So when we talk about risk, we talk about high risk, intermediate risk, and low risk, because this is how the FDA defined it. The high-risk cohort, the FDA mandated that we randomize patients to open surgical valve replacement versus TAVR. So this is high-risk STS, greater than 8% chance of dying in the first 30 days. And at 5 years, these curves were fairly identical. The TAVR group in blue, you can see, has sort of an early trend, but there is a little bit of a late catch-up. But what you realize is in high-risk patients, at 5 years, 60% of the people had died. So, but this demonstrated that TAVR and SAVR were relatively equivalent at 5 years, and that pushed us ahead. That was with the Edwards balloon expandable valve. Medtronic introduced a self-expanding valve around 2 years later that then got involved in these high-risk trials as well. And so again, randomized surgery versus TAVR, 2-year follow-up. The core valve trial demonstrated superiority of TAVR over surgical aortic valve replacement at 2 years for death from any cause. Stroke was 6% absolute better, which is pretty crazy. And then major adverse cardiovascular events were markedly improved. So this was sort of a home run in high-risk patients. So this is kind of the sweet spot which got us going. Also, TAVR valves are much bigger than surgical valves. Surgical valves take up lots of space in the aorta for the structure for the sewing ring. So if we put a TAVR valve in, the inner dimensions of that valve are, in general, are much bigger than tissue valves. And that's also was reflected in these data. So the FDA approved this in January of 2012. We did our first TAVR here, March, I think the 6th of 2012. That patient is still with us and doing great. We were then forced, after that, every patient who came to see us wanted TAVR. Well, we couldn't do TAVR, so we had to randomize everyone. So we partnered here, John Carroll and Dave Fullerton were our PIs for the Partner 2 trial, which was intermediate risk, STS risk of 4 to 8. And it was a randomized trial of surgery versus TAVR. And then the Medtronic valve also did a exact parallel group called SURTAVI. So same patient populations, 2 different valve technologies done in parallel. The Partner 2 trial looked at data out to 2 years in intermediate risk patients. And when you look at death or disabling stroke, there was a significant advantage for TAVR in the blue below at 2 years, with about a 20% reduction overall in these adverse events, which again, this is TAVR is superior to aortic valve surgery in this patient population. In the SURTAVI trial of the balloon expandable, of the self-expanding valve, the data were more equivocal and they were equivalent at 2 years. So the FDA was very happy to push along this with at least equivalent, maybe a trend towards being better with the Edwards valve. The differences in key findings that were pooled between those 2 large studies of over 4,000 patients was that surgery was better for vascular complications, paravalvular leak, and pacemaker rate, but TAVR was better for mortality, strokes, kidney injury, bleeding, new AFib, which is 30% post-surgical AVR, quality of life, 6-meter walk time, ICU length of stay, and days alive out of the hospital. So this scale is probably not balanced in the way that our surgeons were thrilled with. But the great thing about this is our surgeons bought in with us at this exact same time with us, since they're doing the procedures with us and we do them all together as part of a heart team. So in 2016, intermediate risk patients were FDA approved. We followed this out, and Raj Makkar at Cedars, who's one of the largest TAVR operators in the world, published the 5-year outcomes in intermediate risk, and the 5-year outcomes again are very favorable, suggesting long-term durability of transcatheter heart valves with equivalence out to 5 years. That gave us a lot of reassurance when these data came out in 2020 to start enrolling low-risk patients, because now the low-risk patients came to clinic saying, my friend just had a TAVR, I'm not undergoing surgery, I want a TAVR. So the FDA came back and said, great, now it's time to do a low-risk trial. We hadn't even gotten the results of the intermediate risk trial at 3 years when we started enrolling in the low-risk trial in 2019. That's how quickly this moved along. So the PARTNER 3 trial, Edwards balloon expandable valve versus surgery. Patient characteristics, young people, 73-year-olds instead of 85-year-olds, which was our first cohort. STS risk of 1.9% for adverse events. Super low risk patients. This is a layup for open heart surgery because they should have no adverse events. Well, at 12 months, the primary endpoint of the PARTNER 3 trial was death, stroke, or rehospitalization, and TAVR did pretty darn well. This was shocking to everyone who was in this trial, because when we were enrolling, we said, gosh, we're going to be very lucky to show equivalence. Like, we could be a little bit worse, but maybe better tolerated. But this was like a home run around this time. And death and disabling stroke, if you told patients that you're low risk, but you have 3 times higher risk of having a death or a stroke during surgery than TAVR, no one would sign up for surgery. But that's what these data showed. 66% reduction in death and stroke, which is pretty crazy for this technology in low risk patients. We wouldn't have believed that, except we, at the exact same time, we here at the university were doing the Medtronic low risk trial, which with the self-expanding valve using the exact same patient panel. The colors here changed. Sorry about that. SAVR is in blue on top. TAVR is below. Death and disabling stroke at 1 year favored TAVR in low risk patients. So this was the exact opposite thing we thought we would find when we were doing this, and really led to the most rapid adoption of this technology that I've seen of anything we've done in medicine to date. These were simultaneously published in the New England Journal, and the FDA took only 3 years to go from approval of intermediate risk to full approval of low risk TAVR in the United States. So in 2019, so 7 years after the first one's done, we have full approval for everyone in the US. So where are we in 2022? TAVR is approved for patients with severe symptomatic aortic stenosis in the following cohorts that all were studied with prospective randomized trials: inoperable high risk, intermediate risk, low risk. We've done valve-in-valve studies out of our registries, and we've done TAVR and TAVR studies out of the registries where we've gotten FDA approval for use of the technology there. In addition, many of the early trials excluded bicuspid anatomy, but we've added in so many bicuspid anatomy patients into the national registries that the FDA got rid of that exclusion, and now we can essentially treat most anatomies. So essentially, everyone is a TAVR candidate in 2022. There's no regulation over who with severe AS can get TAVR. And now we've turned the discussion over. When people show up to clinic, it isn't, are you being considered for TAVR? It's now, why would we consider you for surgical aortic valve replacement, which is a very important thing we've learned. We never tell patients they're TAVR patients until we've seen a CT coronary angiogram, a CTA, and we've seen their coronary arteries, because those, as you'll see, are the 2 things that are important players. This is the crazy thing. I told you in 2011, we did 45,000 surgical aortic and mitral valves. In the orange is the 82,000 TAVRs that were done in the United States in 2020 during COVID. So, and at that time, the peak surgical aortic valve surgeries was 75,000, has only dropped to 50,000. Isolated aortic valve replacement has actually remained incredibly stable. That's in the red line, has dropped from 30,000 to 15,000. But that's been made up for by this whole huge population. So basically, we've doubled the number of patients undergoing isolated aortic valve replacement in the United States over the last 10 years that were done in 2011. It's crazy. Where these patients were, whether this is therapy awareness, whether all these people just got no therapy before, which is probably the case, is really at play. But we are still doing lots of aortic valve surgery. It's just we're finding patients that are much more appropriate for TAVR going forward. So Patients with bicuspid aortic valves still get surgery now. Many of them have associated aortopathy. This is usually defined as an aortic dilatation greater than 4 centimeters or 4.5 centimeters. And if you have indications for aortic valve repair or aortic valve replacement, and you have an aortic aneurysm, most people would recommend fixing both at the same time because of the risk of late dissection. The other challenge with bicuspid valves, as we'll get to, is that they are associated with very low coronary heights and very long leaflets of the 2 leaflets instead of 3 leaflets. So what happens is we have the risk of pushing the leaflets and covering the coronary arteries when we put the stented valve inside. The other place where we talk about surgery is if you've got left main triple vessel coronary disease and are a diabetic, for instance, you're going to derive mortality benefit from surgical revascularization. Whether we can do a TAVR or not really doesn't change the fact that your coronary disease is driving the long-term outcome. So these are patients that we push towards surgery as the first valve. Concomitant mitral disease, and then patients concerned about valve durability, although I think we've got more and more data now to convince patients that these valves are pretty darn durable, at least out to 5 years. There are some areas that are emerging indications, and I just wanted to go briefly through this because we're actually participating in some of the trials in this area. We all know about severe AS with symptoms. Everyone's FDA approved. There's no longer a question of where TAVR fits. TAVR's for everybody, to be considered in everybody. Severe AS without symptoms. Should we do your TAVR early when there's evidence of structural damage, but people say that they're running, 10 miles a day and doing 14ers with no symptoms, yet they have critical aortic stenosis? We don't know about that. What about moderate AS with symptoms? This is a class 2 indication for surgical aortic valve replacement, but it's nowhere in the TAVR data. So we're trying to sort that out. And I'll go briefly through a couple of those trials. The early TAVR trial is a trial of doing asymptomatic patients with severe AS and basically randomizing them to clinical surveillance versus TAVR. This was supposed to be done in 2021, but got delayed significantly because of COVID, and they're now anticipating the completion of that in March of 2024. So just be aware, we'll have a trial of doing early patients with no symptoms to see if that has benefit. The TAVR Unload trial, our colleagues up at Medical Center of the Rockies are in this trial. This is moderate aortic stenosis in patients with LV dysfunction and heart failure, looking at optimal medical therapy versus TAVR early in these patients. This was also supposed to be done in 2021, but has been kicked out to March of 2023. So hopefully we'll have these data next year. And then we are just starting this trial here. Joe Cleveland and I are the site PIs for this trial. This is with the Medtronic self-expanding valve, and this is the Expand TAVR trial. So this is symptomatic moderate aortic stenosis. And we have lots of these patients that are out there that everyone says, well, you're really dyspneic with exercise, but your resting echo shows moderate aortic stenosis. And one of the challenges is we don't do much stress echo to evaluate whether or not people have severe aortic stenosis with symptoms. It just never worked its way into our guidelines because people used to drop dead doing treadmills and made all of us nervous. So this is an area where we're going to start pushing the boundaries, and we're going to hopefully be able to randomize in this trial here at the University of Colorado Hospital here in the next few months as we get this up and running. The first patient was just enrolled in May, and so hopefully we'll be able to get the 650 patients pretty quickly. What about leaky valves? We get referrals all the time and they say a patient doesn't have aortic stenosis, but they got aortic regurgitation. Of course, you can do a TAVR. Well, TAVR was designed to anchor the valve in calcium, and aortic insufficiency doesn't have a lot of calcium. The other thing is that these aortas dilate over time, and so they stretch. So they're like bigger than aortic stenosis valves, almost 50% in some cases bigger. And so when we created aortic stenosis valves, we actually didn't consider sizes needed to treat aortic insufficiency with the dilatation. Landing zones are difficult. There's no calcium. You can't see where when people have torrential AI, the ventricle connects to the aorta, so you can't see where to put the valve. And then many AI patients have aortopathy that needs to be addressed. And so, we have these challenges. And this is one of the areas of unmet need. This is an example of one of Dr. K's patients we did a while back. You can see a pulmonic valve in the position next to the aorta, torrential aortic insufficiency. But this was a person who had a Ross procedure, and thankfully just the suture line was enough to give us enough anchor to get a evolute valve to hold in place so that we could treat this patient. That the fact that the patient had had a suture there or suture line gave us just enough stability to keep this valve. But treating AI is challenging. When we look at how we do, the need for a second valve implant because of migration in the ventricle, incredibly high, 12 to 24%. Aortic regurgitation afterwards, high. Pacemaker rates are high, 30-day mortality, 10%. So this is a cohort of patients we don't have the right answer for yet, and we really need to develop that. So when you see these patients with wide open AI, we really need to spend more time with them because the technology isn't quite there. The Jena valve has been gotten CE mark. This is a valve that gets anchoring, as you can see in panel B, of basically 3 prongs that sit down in the sinus of Valsalva, and then there are connectors that actually grab the leaflet. So it gets its anchoring essentially at the level of the valve, not with calcium. And this has been done in the pivotal trial. The 50 patients in the US was just completed last week. We have 3 hospitals in the US looking at this. So we should have this valve moving forward, which would be a great valve for us going forward. The unanswered questions in TAVR still are valve durability. If you put a valve in a valve, what is the performance and is it feasible? Some people don't have anatomy where they can have repeated valves put in, particularly small valves. There's an issue of valve leaflet thrombosis, or you guys will see in CT reports called HALT, hypoattenuating leaflet thickening. We think that this has been going on with surgical valves for years. We just never really paid attention to it. And it's probably why we saw surgical valves fail at 3 years, 5 years, and 7 years. It's the same thing we're going to see with TAVR valves. What if you need 3 valves? The 60-year-old, whose mother lived to 96, she's probably going to live to 96 or beyond that. But if she gets a TAVR valve at 60 and these last 10 years, how are we going to do 3 valves on her? Is she going to get surgery as the second one, the third one? How easy is surgery after TAVR? These are the issues. And then I didn't go through this, but the core valve and evolute valve, the core valve gets stabilization in the aorta, so it covers the coronaries. And we have to work through these valves to do coronary intervention and diagnostic angiography. There's an app for it on your iPhone, which means it's difficult to do. So even for us, I've had cases where I cannot do coronary angiography through these valves. So imagine this person rolling into Scotts Bluff with a STEMI, they're probably not going to do well. So in people with CAD, we really try to not put in a valve that's going to interfere with angiography down the road. But these are all things that are unanswered right now. So to conclude this section on aortic valve therapies, TAVR is currently FDA approved for everyone with symptomatic aortic stenosis, including valve and bicuspid. Trials for asymptomatic severe AS and moderate AS with symptoms are currently enrolling or will be enrolling soon. The devices do not currently work for native valve acute regurgitation or aortic regurgitation, but we try them anyways sometimes. We need to better identify patients who should be treated with surgery as their upfront treatment. And we often talk about aortic valve surgery with annular enlargement. You'll be seeing more and more of that. If we're going to do an operation on you, we need to get in a bigger valve. If you put in a 19 millimeter valve or 21 millimeter tissue valve, there's no TAVR inside that that's going to get somebody down the road. So surgery in 2023 means AVR with annular enlargement. And then we need to determine how long and how closely these valves need to be followed. Everyone's getting an annual echo because the valve failure is very unpredictable. We've had people go normal, severe valve dysfunction. And so you do have to have a lot more surveillance. It isn't the go off for 3 years and then we'll see you like we used to do with bioprosthetic valves. Mitral valve disease, thankfully, is a little bit simpler in some aspects, but it's a much more complicated disease. And we've been working in this space. John Carroll and Joe Cleveland. John's been really a pioneer in this with our image guidance from Rob Quaife and our team. This is a 20-year odyssey to where we've gotten today. Mitral valve disease really comes in 2 different flavors. So there's degenerative or primary mitral valve disease. I like to use degenerative because then everybody knows what we're talking about. The valve is dysfunctional because it's been damaged. Functional or secondary MR is mitral regurgitation from either the ventricle stretching or the atria stretching, it stretches the annulus and there's less tissue to coapt of the mitral valve. And so you get leakiness from that. So it's a different pathology than, say, ruptured cords. This is an example of degenerative in the bottom left, where you can actually see a myxomatous thickened mitral valve. You can see the anterior and posterior leaflet, and they coapt fairly back towards the atrium. And this leads to chordal breaking over time and basically flail or partial flail, where you get mitral regurgitation. On the right is a dilated ventricle, where you can see it's stretched and the anterior and posterior leaflet don't have much tissue to coapt and make a good seal. And that's what leads to mitral regurgitation in congestive heart failure in our cardiomyopathic patients. Secondary MR, we think, makes up about 90% of the population of MR in the United States. There are grading systems for this based off the Carpentier grading system, but I really think trying to keep it simple, in terms of just knowing, is it functional MR or is it degenerative MR, really makes the decision making a little bit more straightforward. Almost everyone, maybe everyone, Rob, I don't know, who we're evaluating for mitral valve intervention needs to get a TEE if we're going to think about transcatheter edge-to-edge repair, because the findings of TEE are really predictive of the outcomes. So here's the typical two-dimensional images that you can see on the left, where you can see one leaflet finishing off behind the other leaflet, where there's basically a gap. And you can see that on the three-dimensional TEE images. These 3D images we have nowadays are incredible for mitral valve pathology and help guide therapy. And really, these are interventional echocardiographers are really the key to success for mitral valve interventions in terms of guiding the feasibility of doing it and then navigating and helping us understand where to put things when we do things. Operative risk for mitral valve replacement, as I said, is double that of AVR, maybe triple in folks with severe heart failure. Patients with MR have more comorbid conditions than AS. Functional MR, patients with cardiomyopathic ventricles do not get surgical MVR. The surgeons learned early on that if you take a bad ventricle that has MR and you put a competent valve in, the ventricle fails and you end up in the OR with an EF 10 or 20 points less than what you started. So functional MR isn't treated with surgery anymore. So it's a large population. And then I don't think we really appreciated it. I certainly didn't. The mitral valve structural relationships are far more complicated than the aortic valve. You think the aortic valve, oh, it's there, it's above the mitral valve, the coronaries are right there. Mitral valve's far more complicated. We'll go through some of that. So I'm going to briefly go through the mitral valve repair and replacement. There are two different strategies for this. It's repairing the valve you have, or let's put a brand new one in there. Those are kind of the competing technologies in 2022. Dr. Alfieri in Italy came up with this novel idea of, if you've got a leaflet that closes behind the other one, how about you just stitch them together? Don't worry about repairing the cords, and you basically trade off a little bit of mitral stenosis for improvement in mitral regurgitation. And the Alfieri, he did this over in Europe and has done thousands of cases of this. And when you looked at the long term, this is out to 14 years, freedom from reoperation is like 90% in this cohort. So he kind of came up with this incredible concept that basically the engineer said, gosh, we can do that. And basically they came up with the way to do this with a transcatheter based approach with clipping. So the Microclip was the first to do this. This has been followed by the Pascal device, but the Microclip is what we basically did, is we would clip the anterior leaflet to the posterior leaflet. You'd trade off some regurgitation and create a little bit of stenosis, but still have a big double barrel orifice for blood to flow. The other thing is that what happens if the valve is stretched out? Well, you can do annuloplasty. We can shrink down the outer edge of the valve and make it so that there's more tissue to coapt and get rid of mitral regurgitation. So there's the Carillon system that basically is a coronary sinus stent system that cinches down the mitral valve and decreases the annular area so that it reduces mitral regurgitation. And then, much like the surgeons do with annuloplasty surgically, where they take these rings or semi-rigid rings and basically shrink down the valve, we can do that with catheters and basically put rivets in the ventricle from inside the beating heart. So all this stuff is quite crazy when we start doing it. Microclip, though, isn't a new thing. Like John Carroll and our team started the Everest Trial back in 2002. So we're 20 years into Microclip in the mitral position, and it's still not clear where its roles are. And there have been a number of trials. It was finally FDA approved, as we'll go through, based off the Everest Trial. The Everest Trial took patients and said, with degenerative mitral regurgitation, you're going to get surgery or you're going to get the clip. And what they found was the clip wasn't as good as surgery for long-term outcomes at 5 years, and there was a high reoperation rate. So the FDA said, we aren't going to approve it for everybody with degenerative valves, but they did looked at subgroup analysis, and patients that were high risk actually did as well with MitraClip. So they basically went ahead and kind of approved that. Interestingly, I don't know how we snuck this in, but we snuck in like 60 patients that actually didn't have degenerative mitral regurgitation. They had functional MR, and they got surgery or MitraClip. And based off of these 60 patients where the outcomes were the same, the FDA said, well, gosh, maybe you guys could do a trial on this. And this basically spurned the Co-Apt Trial, which Andreas Brique was our investigator here at the University of Colorado. The clip works darn well. This is MR severity grade. Red and orange is 4+ and 3+. And if you look out to 1 year and 2 years, people do pretty well. You don't get rid of MR, but you can make it a lot better. And that's where MitraClip does with functional MR. It takes you from severe to moderate, and that's sometimes just enough. This is an example of one of our cases from 2012. You can see severe eccentric mitral regurgitation pre-clip on the left. This is their 6-month follow-up echo on the right. It's not perfect. There is MR, but it certainly is much better. You can see the atria are smaller, the ventricles are smaller. So we've improved myocardial performance with this technology. So the FDA approved MitraClip in 2013, a decade into the investigation, so totally different than TAVR, for degenerative MR only for patients that are high risk. So this is an STS risk greater than 8%, which isn't very many people, but this was basically limited. And now the decision needs to be made with the heart team between a cardiac surgeon and the heart team. Well, what about the 90% of patients with functional MR? That was this group. This was the Co-Apt Trial. And the Co-Apt Trial was basically a trial of guideline-directed medical therapy, including biventricular pacing, compared to use of the MitraClip plus GDMT in patients with moderate to severe or severe functional MR, despite maximally tolerated GDMT. Every patient had to be seen by a heart failure certified specialist. So this really is a heart failure trial. This is an amazing trial. So all hospitalizations for heart failure within 24 months, this was a 50% reduction in heart failure at 24 months, with the number needed to treat to prevent heart failure readmission of 3. So heart failure admissions are super expensive. So this is like a home run from a cost effectiveness standpoint. And this really pushed us forward in this patient population. But this is what was really important, is that we made their heart failure better, but the patients didn't die. So this was a 40% reduction in mortality over 2 years. Number needed to treat 6 to save a death. This is like TAVR in inoperable patients. It's like a complete home run in terms of device treatment on top of GDMT. So the Co-Apt trial, really, which was just published 3 years ago, was really the shown to improve prognosis of patients with heart failure, and open the doors or the floodgates for clipping patients with medically refractory heart failure. So these are the 2 indications for MitraClip. You'll also see this in the literature as TEER, T-E-E-R, transcatheter edge-to-edge repair, because some of mitral valve repair can also be annuloplasty. But in 2020, the FDA approved the Co-Apt patient cohort. CMS didn't start paying for it until 2021. So we're just now getting into seeing these patients as clinically indicated. MitraClip is equally disruptive. It now requires the heart team to include a heart failure specialist. It's led to an explosion. There's 575 MitraClip sites in the country, which is crazy. It's better than GDMT. So actually every active clinical trial that was underway in 2019 had to be stopped. The control arms had to be redesigned to include MitraClip as the best practice at the time. So this has delayed a lot of our technologies as those trials were put on hold. And then MitraClip has a challenge. You got a clip in the way of a transcatheter heart valve. So it prevents you from doing things. So now we have people out there designing tools to remove the MitraClip as you're putting in the transcatheter mitral valve. So it is a blocking technology in some respects, in that you can't really do things inside the valve, but there'll be ways to get around it with these technologies. I'm going to talk briefly about the mitral valve technologies. This is the ability to put in basically a scaffolding underneath. This is the MDOC. So you basically put a scaffolding material in the chordae, and then you put a TAVR valve inside that scaffolding. This is one approach that's being used. We talked about annuloplasty things, and ways to put in new cords are being looked at for mitral valve repair. I think the most excitement is about putting in a whole new valve inside the valve. The Tendyne trial, which we were in but couldn't enroll because it's a transapical trial, and it's a huge device that takes up a ton of space, and so about 85% of people were excluded from the trial, is being replaced by these transeptal devices that have much lower profiles and don't take up much space in this. And several of these are fairly far along in terms of the first in-man trials. The US approved TAVR. We were the 48th nation in the world to approve TAVR. Japan was behind us. The FDA said we are going to be the first to approve mitral valve technology. So all of the first in man are being done in the United States this time around for mitral. The challenge, as I mentioned earlier, is the mitral valve is a difficult valve. When we put a valve inside of it, the anterior leaflet sits in the LV outflow tract like a spinnaker and blocks blood flow from going out the valve, which our surgeons never had to worry about because they cut it out when they put in the valve. But so we have to now figure out how to deal with the anterior leaflet of the mitral valve. And the other thing is it's an oval valve. It's not a round valve. And people have lots of different anatomical changes. In the US, the most common thing we see with mitral regurgitation is severe MAC, or mitral annular calcification, which makes anchoring these valves and getting a good seal very, very difficult. So we've got a lot of work ahead of us in terms of where these transcatheter mitral valve technologies sit. These are just two different designs: a valve that sits above, and this is kind of what the ideal valve would be, which is the Intrepid valve on the left. This is that MDOC I was talking about. Both of these are in clinical trials here. Our friends up at Medical Center of the Rockies are involved, I think, in the MDOC study of that. So very excited to have that here in Colorado. I mentioned some of the technical challenges. These things are huge. Like, transcatheter TAVR valves are now going through 14 and 16 French sheaths. These are 26 through 36 French sheaths. So this is back to the early days of TAVR, but these are going through the tip of the heart. So they make big holes. So we need to navigate that. We talked about the LV outflow tract obstruction, which is the Achilles heel of this, but there's also conduction system abnormalities. Interfering with the circumflex flow, which runs right behind the annulus, is important. Also, there's valve-related events. These things thrombose at the drop of a hat. So everyone being considered for transcatheter mitral valve replacement trials have to be candidates for long-term oral anticoagulation, which doesn't jive with this population at all times. So these are just some of the things we'll have to deal with, but I think it's very, very exciting how quickly this is moving. Mitral valve repair and replacement timeline is going to be much, much longer. These patients are harder to pick out. There's lots more anatomic variability. The transcatheter repair with MitraClip right now is the only FDA-approved approach for high-risk surgical patients with degenerative MR, and for patients with heart failure and moderately severe to severe functional MR refractory to GDMT. We're working on these, and I think that's going to be an exciting next few years. In the last 5 minutes, we're going to go through the forgotten valve. It's always the last. It's forgotten. This is a slide I got from John Carroll. You talk about Canon V waves of wide open TR. We so infrequently see this. This is just a great example of a patient he saw with torrential tricuspid regurgitation. And you can see with systole, there's just regurgitation into the IJ. This is not, JVD. This is actually a pulsatile, internal jugular. These patients present with hepatomegaly, jaundice, ascites, peripheral edema, and cardiac cachexia, and are very difficult to manage. Tricuspid regurgitation carries with it a very poor prognosis. If you have severe TR, these people do very poorly when you follow them longitudinally. I have only seen 2 or 3 people who've had tricuspid valve surgical repairs. It just isn't done much. The STS decade experience was 54,000, so that's 4,000 a year, not very common. The reason is 10 to 12% of these people die in the hospital or in the first 30 days of their surgery. So it's not a low risk procedure. We have direct suture annuloplasty approaches. We've got ring annuloplasty approaches. There's coaptation enhancement devices, and there's transcatheter valve replacements being looked in this. This is a 3-leaflet valve as opposed to a 2-leaflet valve, sometimes a 4-leaflet valve. The tricuspid valve is very funky, and the RV is not circular. So you're trying to like tie things together to get a competent valve that aren't naturally wanting to be tied together. The folks that make the Microclip came up with the Triclip. It's basically the same thing. It's a shorter delivery system, has some enhancements, but basically you're trying to clip multiple leaflets together to create a valve that doesn't leak much. And in the tricuspid position, we're not talking about trivial or mild as a good result. Now there's torrential as a category. So like we need to get it to moderate from torrential, and we think that's going to be associated with good outcomes. John Carroll and Ken Desai are recruiting here. So if you see patients with severe tricuspid regurgitation, we're enrolling in the Triluminate pivotal trial. There's an arm that's a single arm that people just get repair if they have horrible protoplasm. If they're reasonable patients to be randomized, they'll be randomized to Triclip versus medical therapy. And this study is enrolling very quickly, and it'll be a pivotal trial in the United States. Our friends up at Medical Center of the Rockies are in the Evoke trial. This is a tricuspid valve replacement trial. This device has to get anchoring under the valve and above the valve because, again, there's no calcium. These are huge valves. And so the valve sizes, when we talk about TAVR, 23, 26, 29, these valves are 44, 48, 52 millimeters in diameter. So these are big Mack trucks you're trying to drop into the dilated right ventricle to try to get this. 28 French delivery system. It's in the venous system and tolerates that a little bit better than arterial. But these are big things, and we'll see as all of these trials are rapidly enrolling. So to conclude, transcatheter valve therapies have been disruptive, and they've changed treatment of aortic valve disease completely in 10 years. The mitral valve is far more complex, the timeline's longer, but we have a lot of very exciting technologies that all of you are going to see in the next 3 to 5 years come to fruition. The tricuspid field is moving very quickly forward because there was nothing to offer these patients. So I think we'll find out faster in the tricuspid space than we will in the mitral space. And these novel valve technologies and innovation are all driving the field towards complete endovascular approaches for treating valvular heart disease. So this is going to require a complete redesign with our heart team, how our cardiothoracic surgeons are trained, how we train in cardiology in terms of the overlapping skill set of these going forward. Thank you very much for your time today.
Dr. Messenger, that was great. Thank you very much. Questions from the audience to start? Nancy?
Thank you, John. That was really interesting. I actually have 2 questions.
Sure.
One, could you talk a minute about the logistics of going to the cath lab, coordinating with CT surgery, and how that happens? And then the second one, of course, is infectious complications that you might be seeing.
Fantastic, great. So one of the things that I skipped over, and I apologize, I have a whole grand rounds on the heart team approach and how we've gotten everything together, is that we actually merged our clinics with our cardiothoracic surgeons. So we actually have multidisciplinary clinics now. It's a one-stop shop. The patients show up with it, come get a CT scan with us. They see a surgeon and an interventional cardiologist together. They get all their assessments of frailty. We get the CT scan read out that day by our imagers so that we can have a decision with the patient, have a patient-centered discussion over what the right technology is. And then we arrange any testing. Angiograms and things like that we'll usually set up with their referring cardiologists oftentimes outside of our hospital. And then we basically have them show up and everything's ready to roll when we have their TAVR date set up. But it's a true one-stop shop for them in terms of multidisciplinary planning and discussion. In terms of the infectious complications, infection endocarditis is a big deal. In the original partner high-risk study, it was about 2% at 2 years in the trial. And it's something that we've seen. We've actually have had 3 patients that I know of that have had endocarditis with it. 2 of them, all of them we've managed medically because they were all deemed to be inoperable or high risk when they got their valves. And one Brett Reese operated on actually and had to do a valve replacement because he had a ruptured aorta from the infection. Those are the 3 that I'm aware of. We've been shocked with the relatively low rate of it, considering we've done now 1,300 TAVRs here. We've been surprised. We're very aggressive about SBE prophylaxis, probably overly aggressive in terms of, as I tell folks, you can't get a valve infected if you aren't a candidate for it to be replaced. And so we probably over treat. So we do these all. I've got somebody, on the table currently waiting for me. So we do these in hybrid operating rooms. So we have OR7 here is a hybrid room with a C-arm, or not a C-arm, it's a full cath lab. And then we have a cath lab we built. Room 15 is actually a hybrid operating room that meets all the AORN standards for open heart surgery. And so usually we'll bounce back and forth between those two. We do 3 to 4 of these every Wednesday. And do it with our surgeons. Today, I think I'm with Jordan Hoffman, who's our new surgeon from Vanderbilt, who we trained here, and Brett Reese. It's a team effort. Dr. Quaife is doing our ultrasound imaging for it. So we do them exactly like it's an operation. We have to convert about 1 out of 200 people to either on pump or open heart surgery. And we do it with our full support. But knock on wood, we've had very good success with our program to date.
John, can you talk a little bit about how you work with biomedical engineers on this? I mean, some of these devices almost seem like magic. It's like you wish they had a thing that did this, and then they have a thing that does that. What's that development look like?
Yeah, we've been able to partner with industry pretty closely in terms of working with, we've done a number of device trials with, I didn't show the 3 or 4 trials that we've been involved with for valves that never came to market or didn't prove to be as good as the current ones. But we've got great engineering relationships with this. James Chen, who's here with us, James runs our 3D lab, and we've done multiple industry projects off of 3D modeling using data sets so that we can they tell us what the valve looks like. We tell it what it's going to look like in the humans using real human data sets. And that's an area of research interest for Rob and James going forward with our CT program. It's fascinating to work with the engineers because you can tell them, at Edwards, who's got 2,000 engineers, they can invent something and bring it to prototype literally within a week. And so it's this super rapid iteration that's driving all this technological advancement. And the TAVR sizes, if I would have showed you the catheters, the first TAVRs we did in 2014 and 2015 were 26 and 28 French sheaths. So everyone got a cut down. We're doing them now through 12 French sheaths. So these are like 60, 70% reductions in size in only 4 or 5 years through engineering. So we've got a great working relationship with them. We've got a development program here where we partner with them as well in terms of the development, and it's exciting to work with them. We've not worked as closely with our engineering department here in terms of on-site development, but I think we'd be obviously open to that going forward. There is one company in Colorado that is actually a heart valve company that we got started with, but haven't been able to make inroads because of COVID. So.
Do you think we'll be seeing these transcatheter approaches for younger and younger patients, like bicuspid valves, in the next 10 years?
Yeah, we're already doing that. I mean, we've treated down to our 20-year-olds that are high surgical risk, particularly in our ACHD patient populations that have had 2 and 3 sternotomies already. And so we're already moving these. I think we've done it in a number of people with Hodgkin's who are in their 40s and 50s. So these are things that are going to be treated there. The big question is, what do we do next? I think that's going to be the big question, because this is what people want now, and they're willing to gamble a little bit of there'll be something better in 10 years that'll be a better solution. But it's pretty uncommon for us to be able to really convince folks to get away from TAVR without a pretty good discussion of why we think they shouldn't get TAVR. The folks that respond the best to you need an operation are those with an aneurysm who are more worried about an aortic dissection than they are about the aortic stenosis. But most people want TAVR at least to be considered. So it's forced us into this younger group. But I didn't get into transcatheter pulmonic valve. I mean, we're using, Gareth Morgan and Joe Kay are using these in 20, 30, 40-year-olds in the pulmonic circulation. We're using them in the tricuspid circulation. So this is something that is spanning, all age ranges, unfortunately.
All right. I don't think there are any more questions. Perfect. And it's 1:00. So, John, thank you very much.
Thank you.